At the outset, I would like to thank Dr. Lalit and also the scientific committee for giving me this opportunity. So, the topic that was given to me was biomarkers and the road ahead. Can we really titrate or prognosticate? Now, what is the understanding till now is what is a biomarker? It is a measurable indicator of a biological process, or it is something that helps us to determine whether there is a response to a therapeutic intervention or not. It may be a biochemical biomarker or a molecular biomarker. It can be a genetic biomarker which can tell whether a disease is going to be more severe than others, or imaging based biomarkers. We as ophthalmologists tend to use more of imaging based biomarkers, and every single time we tend to do the treatment based on it because it is repeatable and available to us. This can be used to diagnose, monitor, and also predict the disease progression. It can help to predict the response to treatment as well. Now, biomarkers enables us also to understand the underlying biological mechanisms of the disease and to identify potential therapeutic targets. So, if you're using only one type of biomarker, you might not be able to understand what is happening at the microcosm level. So, looking at only a single type of biomarker might not help us to look at the full picture. So, any ideal biomarker should help us to make more accurate diagnosis, understand the disease process, and also herald the way for more and more customized treatment, because we all know that the same injection can produce different effects despite having the similar kind of an OCT. Now, what is known to all of us is this. The commonly used ones are the OCT biomarkers. You know that if you have a hard exudate at the fovea, it means that the patient probably will not improve in his visual outcomes. It is also a marker of chronicity. Usually, it takes about 6 to 12 weeks for development of a hard exudate once the edema disappears. Also, sudden disappearance of edema can suddenly precipitate a hard exudate. If it happens at the fovea, it is a bad marker. Neurosensory detachment, if it is there, we look into the systemic associations. Is there any presence of hypertension, hypoproteinemia, etc., etc.? And that again, based on the image, can tell you about subsequent disease. There are others which are very clearly seen on the OCT, which are like bridging processes, which will tell you that, oh, they might respond to treatment. VMT typically changes the way we manage from medical management to surgical management. There are a few others like pearl necklace sign and large cystoid traces, which typically indicate that the disease has been more chronic in DME. Now, similar biomarkers can also be seen on the OCT for AMD. So we tend to classify the disease as type 1, type 2, depending upon where the membrane is, and subretinal fluid definitely means that there is an activity, which means that you continue with your treatment. Pigment epithelial detachment will tell you that the vision does not get affected, but this will probably be a patient who will be taking a very long treatment. Uh, Something like a precordial cleft can tell you that the disease is active, but it's not going to rob the patient of the vision. Outer retinal tubulations mean the patient is at the end of the disease, and hyperreflectivity dot means that these patients are going to respond relatively less than what is given. But what I was called for, or when Dr. Lalit called me for this talk, was for this. Now, we are looking at one part of the disease. What happens if we try to understand the disease to look at the molecular biomarkers? So, if you look at aqueous humor of patients who are taking treatment, you can see that it reflects the true nature of the disease. We treat the patient by giving anti-VEGF usually in most patients of diabetic macular edema. So naturally VEGF-A is high, but what happens over a period of time is, if you look at a patient who's been recurrent, the VEGF levels are not going as up as when it was treatment naive. So there are other factors which are there, like the soluble LICAM levels, which tend to become more and more up, and the inflammatory factors like IL-6 also tend to go up. There are extracellular modulation factors like MMP9s, which tend to go up. Integrin 1 beta and IL-1 beta also is a chronic inflammatory marker. So whenever there is a chronic inflammatory marker up, there is also presence of IL-6 which is going up, and soluble ICAM levels going up. So this is one thing that can tell you that the disease is entered into a chronic inflammatory phase, which is as much influencing the disease as VEGF-A. Now the common argument is, okay, we are giving VEGF, it is trying to take it's trying to give you good enough vision or keeping the patient under good treatment. So why do we need to see this? This particular thing will help us in more and more tailor-made treatment, but of course we need more and more targets for that. Currently, the target that is available is intravitreal steroid, but what steroid does, it kind of blanketly suppresses everything, both the good and bad part of it. And another problem with steroid is it can cause glaucoma and cataract. I mean, that is what keeps us from using steroid as the primary line. So if individual of these can be blocked particularly, that can help in treating the patients better more and more in the future. So this slide actually indicates that these biomarkers can be looked into if we are trying to customize and tailor make the treatment, but the availability of targets is something that we look forward to. These are the ROC curves. Now, the other question that many people ask is, okay, if I look at VEGF levels, can I tell the disease is absolutely active? Now, you can see the distribution here. Not every patient of diabetic macular edema has a very high level of VEGF. There can be other things which are kind of going up and down, like I showed in the previous slide. So you can see the clustering that is there, the controls and the DME, they are relatively there, but there are few patients where they're going up. So based on our knowledge of understanding of pathomechanism in printed literature, we tend to say, okay, whenever there is DME, there has to be an increased VEGF level, but that's not really the case. If you put an area under the curve and you look at what is the sensitivity of it, the sensitivity is only 71.43%. Now, if you look at ICAM now, ICAM actually correlates more than VEGF-A, but the commonly used drug that we are doing in current practice is VEGF, which means that we are not exactly treating the pathway or the way in which the disease should be treated, or probably there are new targets that are upcoming. Now, I'll show you an example case where we had taken aqueous humor and correlated with the OCT. This thing, you look at the level of cystoid space probably is inflammatory, or but you can see that the VEGF level is very high. In another case, which had cystoid spaces, but there the VEGF level is too low. But both the cases responded to anti-VEGF, which means that anti-VEGF probably has a polymorphic effect. It might be affecting other pathways as well. But then over a period of time, it tends to lose its effect on those receptors because they tend to get saturated. Now, this is another patient where you can see that there has been macular edema where I gave an injection. So the first one is when the patient presented to me, despite having about 1,000 microns in edema on the OCT. In OCT, you can see that after I gave the patient an injection of anti-VEGF plus steroid, the level of VEGF actually fell down even further than what would have usually happened, right? But after about 2 months, the patient's VEGF level came back. What this example indicates is that tailor making of treatment is possible. If you tend to target individual biomarkers, probably it can lead to lesser number of injections rather than just looking at cheaper alternatives. If we understand the disease, probably we might treat it better. Now, another question that is commonly asked to us is, you have to take an AC tap, so this is an invasive procedure. So what we are working at Narayan Nethralaya is this, that probably look at all the biomarkers, keep the data, analyze the data, and probably correlate it with tears. Although we are not there yet, we have analyzed about 40 factors, out of which only 3 to 4 kind of correlate between tear and aqueous. So a day might come when somebody can take tears and put it on a multiplex ELISA like that, read it in a machine and give you a printout where you can understand the pathways that are involved and what is the current stage of the disease, and probably choose your anti-VEGF injection. Thank you so much.